So I think one of the most basic and important skill set you need with providing any mental health care is to understand how to evaluate safety and understand phenomenon such as self-destructive behavior and at the extreme suicidality in the context of the individuals who seek our care. So we approach this in a way that really helps us clarify our thinking, because I believe that one of the things that works best about the evidence-based treatments for BPD is that it gives you a clear framework with which you can make decisions. And what we want to do in GPM is to remind you that you need to think first, and you can rely on your own good training and judgment to determine what to do with these patients, if you can calm yourself down and be active and not reactive. So this is how we talk about suicidality for people who have BPD. We explain to patients that when you experience stressful interactions with someone close to you, that is family or friends, emotions can really get intense. Terrible thoughts may come across your mind, and you can do things without thinking of the consequences, as if to relieve something inside of you. And oftentimes patients will really relate to this. One way to organize the experience of becoming more unstable and approaching problems of self-destructive and suicidal behavior is to use the interpersonal hypersensitivity model. So you'll remember this, is that when people feel connected to someone that's important that they trust, they're feeling more comfortable, but they're still anxious about rejection and a possibility that that person won't be there for them. And the problem with that is that your whole sense of self is invested in the availability of someone else, and that's just doomed to fail, right? So easily they'll feel threatened, and in the threatened state, arousal goes up. And what happens is our ability to think clearly, strategize solutions, and understand the situation coherently and realistically goes down. That's for everyone. For people with BPD, it happens at a lower level of stress. So they perceive that they're under attack, or there's something that's kind of upon them that's too overwhelming. And this produces that threatened state where people become irritable. When you're cornered and wounded, you kind of lash out. That's animal behavior, human behavior. So this kind of irritability and anger is either turned inward as self-harm or turned outward as kind of interpersonal devaluation, blame, hostility. But in that state, the person is still very much invested in interacting, right? So this is actually a very productive moment to understand that anything that happens in this angry, expressive state is actually still okay. So if they're screaming at you and yelling at you or expressing high levels of stress and needing your help and being interested or sensitive to your behavior, that's actually a good sign, because they're still available to intervention and they're still sensitive to how much you can support them. It's in this state that self-injury occurs, and self-injury is pretty broad. It can include overdosing on your medication without suicidal intent. It can include deliberate self-injury to the body. Boys do more self-battery, and girls will do more cutting. But these behaviors are just signs of stress. They're ways that people cope with arousal. And actually, researchers in Germany have found that for people with BPD, when you cut yourself, your stressful arousal goes down. But if you don't have BPD and you cut yourself, your stressful arousal goes up. So there's something neurobiologically different about people with BPD, and in fact, they also found that the connection between the frontal lobe or the frontal limbic cortex and the subcortical kind of arousal centers like the amygdala are reinstated by cutting. So people with BPD do this out of some knowledge that it helps settle them. It's just, the problem is it's self-destructive and not very adaptive. But even more so, it scares and confuses people. So then when people are either devaluing or self-harming or both, they paradoxically push away the very people that they need help from. And that's when they become more dangerously behaviorally discontrolled, because they don't have a kind of anchor in reality, so they have no sense of consequences of their behavior, and they become more paranoid about people. So once they're in this reckless state, it's already a little bit too late to try to intervene and collaborate with them, because they're already feeling alone. And John Gunderson actually wrote a paper in 1996 called the BPD as an intolerance of aloneness. Because you don't have a sense of self, you need others to help organize and contain you. And then this behavior actually creates so much adversity that then you just descend into despair. And this is where people are more seriously suicidal. So if they're disconnected, when they're not supported or grounded in reality, this is when you worry more about actual suicide. There's something kind of adaptive about this, because these are kind of smoke signals that go up in the air, and then people get concerned and they do something about it, whether it's putting them in the hospital, showing more family support, or even calling the police. That reconstitutes social support or even social interaction to get people more connected or even more threatened. That's better than having them despairing. So after explaining this, or just understanding this together with the patient, maybe with their family, you can say, the good news is we can work together to develop new ways of coping with the intense emotion and impulsivity that comes up for you when you're stressed. But we also say, while I can help you to manage these behaviors to diminish their cause, we also need to help you find better social supports, people to help you with those situations. So this actually is a very complicated message, is that we're telling people, it's kind of like in diabetes, when people have polyuria and they become thirsty, we can kind of like deal with those problems superficially, but unless we solve the underlying cause of those symptoms, we're not going to get very far. So we can temporize the situation, but more broadly speaking, what we have to get them to do is stabilize their world psychologically so that it's more realistic and reliable for them. So what you need to know about the tendency towards self-destructive behavior in BPD is really something that comes down to assessing dangerousness. And oftentimes statistics helps orient us to the probability that something's more or less dangerous. Now, this is actually more difficult in adolescents than it is in adults, because adolescents do commit suicide, and they have very little psychiatric history with which you can gauge the probabilities. They're more impulsive, and they're more likely to take risks. So we know in this group, because other causes of death are not that prevalent for adolescents, that suicide is the second leading cause of death. And there's a significant risk for suicide for people with BPD. So some studies, older studies, said that 1 in 10 people with BPD will die by suicide. Then more modern studies followed people with BPD for 20 years. They said actually maybe it's between 3 and 5%. But those studies happened at like Ivy League institutions like Harvard, so it's not the typical patient. And I've had colleagues in social healthcare systems like in Australia, where they look at coroner's reports, and they still estimate closer to 10%. So the rate of suicide in this population is quite significant, but the hard part of managing this clinically is that 9 out of 10 people won't die of suicide. So how do we know which ones are more at risk? because so many people with BPD will engage in some self-destructive behavior, we have to be a little bit more specific about what are the factors that puts a specific individual at risk. We do know having BPD increases the rate of suicide or the risk of suicide 50-fold over someone who has no psychiatric problems. When someone is young, they don't have a psychiatric history yet. They're starting to build one. And what we've learned from studies of adolescents is that the average time from thinking about self-harming to actually self-harming is about 6 months. And then starting to think about suicide to actually trying to commit suicide can be 6 months to 12 months. And actually, even though self-harming, deliberate self-injury, and suicidal attempts are quite different, for adolescents, this tends to evolve over a period of 1 to 2 years if there's not proper intervention. So this is actually much more difficult for clinicians working with young people, because for a lot of people with BPD, or a lot of adolescents, about 50% of people will do it at least once and never do it again. But actually, there's 50% who will try to kill themselves more than once, 2 or more times. And every time they try to do so, it escalates risk for another attempt. So it's a dynamic assessment, trying to understand who's at how much risk when. And that's why we get all this training. So while deliberate self-harm, like cutting, self-battery, burning, is not immediately dangerous and may be stabilizing, it also increases ultimate risk for completing suicide. So how does this happen? Suicidologists know that there are many risk factors for increasing risk for completed suicide. There are things that promote suicidality and things that protect individuals from suicidality. A feeling of belongingness, a feeling of not being a burden to others, and fear of personal injury. Those are actually protective factors. And what deliberate self-harm does is it habituates young people to self-injury and harming one's physical body in a way that reduces the barrier to suicide later. So that's something that you have to keep your eye on. But what we do in GPM is we try to evaluate each episode in terms of its level of dangerousness in the moment. And I'll tell you how to do that. The difficult thing about this is that people who are suicidal and are driven to actually do something about it, they actually oftentimes will report that they're ambivalent. There's a part of them that wants to die, and there's a part of them that will regret it later, their attempt. And so those who have BPD that are interpersonally sensitive and they evaluate their self-worth in terms of responses of others, they oftentimes will say, if I'm rescued, if I'm important enough to someone else, then I want to live. But if nobody cares about me and nobody tries to rescue me, then I'd rather be dead. So it is something that we feel a lot of pressure about, because what we do about it actually does make an impact. But even more complicated is that suicidal acts in adolescence are more impulsive than they are later. And people, younger people, have less equipment to understand themselves with. So when you ask teens why they tried to take an overdose or jumped out a window or tried to hang themselves, they just say things like, I just wanted to take pills, so I did it. It doesn't give you much to work with. But you do have to help them understand this over time. So like I just said, adolescent self-injury is a strong predictor of suicide attempts. You know, what will happen for a lot of young people is they'll try it once, it doesn't really work for them. A lot of people will become concerned and preoccupied with them, and then they'll decide it's not worth it. You know, there's something else I can do. It doesn't give me the reward that makes this effective for me. And generally, the kind of attention that's brought to the young person when they've self-harmed, it provides enough relief that people care, and then there's more of a dialogue about what is going on for them. And that, for some cases, are enough. The average age of onset of self-injury is pretty young. I don't know if you know the movie 13. Yeah. So it is really around that time that a lot of experimentation goes on, a lot of decreased supervision. So young people are just trying a lot of things. And it's in that framework that youth will try self-injury, just like they'll try other things. But those with BPD will oftentimes say retrospectively that they started self-injuring maybe even earlier. Like I said, the kind of stressful challenges on them exceed the amount of support or capability they have to deal earlier. And for some youths, especially those with other mental health problems, they may continue this into adulthood because the stress is still ongoing, and the increase of skills or capacity or tools to deal with it is not sufficient. So this is something that is contextual for each individual, but it's also biological. Like I said, there are some changes that occur physiologically and neurocognitively that show that those with BPD process these experiences quite differently. So, for example, people who have BPD have what we call pain insensitivity. So this is actually pretty interesting because a lot of people with BPD or people who self-harm will say, I want to inflict pain on myself because I'd rather feel physical pain than emotional pain. Or they'll say that I'm numb, so I try to hurt myself to not be dissociated anymore. They'll refer to multiple functions of the activity. But what we do know about pain sensitivity is that those with BPD, when they're compared to people who don't have BPD, and you put painful stimuli like heat, again, the Germans did this. You can have whatever judgment you want about that, but they have very flexible IRBs, I think. But they will apply painful stimulus to those who have BPD, and they don't tend to find it as painful at higher temperatures as people without BPD. But what's interesting is that as their BPD symptoms go down, their pain sensitivity goes up. So there's something that I find that people walk on eggshells around those with BPD, but I generally tell people they're better at dealing with certain kinds of stress than we think. Like painful stimuli is not as painful to them. Interpersonal conflict is not as unusual for them, so they're kind of more habituated to certain stimuli than you might imagine. So this pain insensitivity, that's what I said, contributes to the danger to complete suicide at some point in time. And that's why you want to intervene earlier, because as you decrease the BPD symptoms, their pain sensitivity goes up, and they'll be more responsive to those social experiences they have that help most of us learn. Sometimes you'll meet people with BPD and you'll be confused by how come they don't learn from their mistakes. And it may have differences in how they process pain and other self-experiences. Okay. Now, in young people, in a retrospective study of suicides for people younger than 19, we find that it's greater in countries where there's more poverty. So, in general, the rate of suicide is about 8 per 100,000 youths between the age of 15 to 19. But for those who actually are suicidal earlier on, the risk factors seem to be high family conflict and low parental supervision. So it's not just that the person has had trauma. I think trauma is too non-specific a term to understand the pathogenesis of any outcome of trauma. Trauma increases the risk of most psychiatric problems, not just BPD. But it's really the combination of adversity versus support and supervision. Who's there to make sure the environment of the child and the child's activities are safe and healthy. But as kids enter adolescence, they want more privacy. And my own personal theory of this comes from being a parent, is that when people don't have a very stable sense of self, as teens normally do, they need more physical buffers from people. So when my daughter turned adolescent, she all of a sudden wanted her door closed all the time, and the do not disturb signs? She made one, but she misspelled disturb. She was do not disturb. But she needed more space to herself to make up her own mind. Like, my opinion was like, it's suffocating because it's too strong, too clear for someone who doesn't know what they think yet. So the problem is that teens are starting to figure themselves out and they need more space to do it, but they're not necessarily sending social signals to the people who are taking care of them in a way that's going to get the support they need. So this makes it more complicated. So what we say about this is that with just self-injury, deliberate self-injury, not suicide attempts, you can do a number of things. If you look at the Cochrane Review of treatments for self-injury, there's only CBT, DBT, and MBT. But this brief CBT for self-harm, I've almost never seen it. Have you ever seen that practice anywhere? I mean, all of us BPD experts, I've never even had the opportunity to learn brief CBT for self-harm. But that apparently is effective. If you know how to do that may be indicated. But medications will rarely diminish self-harm. It's like treating the polyuria or polydipsia of diabetes without providing some support of insulin insensitivity or lack of insulin production. So there are some key clinical recommendations we make that are just general about self-injury. Is you want to respond with supportive concern. Don't overreact, because it's not immediately dangerous, but it is concerning. You want to put the self-harm as a kind of smoke signal of some other problem that the person is having. Too often we take the self-harm in isolation and try to get rid of it, but really it's a sign of something else that has to be addressed. But the young person isn't very good at expressing or even knowing themselves what it is. So what we say in GPM is you want to proactively ask about the interpersonal stressors that precipitated the anguish. Teens find their social world stressful. So just getting them to talk about it, you might be able to find out what happened. And then you want to talk to the patient and their family about what self-harm means to the patient and the consequences it has. Families get very scared about this and they just want the self-harm to end. But what we try to instruct families about is that this is a sign that your son or daughter is just distressed and that they need your concern and support. So what's more important than getting rid of the self-harm is getting your son or your daughter to talk to you about it. Because the more they talk to you, the more you know about how to understand their difficulties and what to do if they ask you or let you help. Now, turning to suicidality, we want you to rely on the things you